Well, good day to all. My name is Eric Brenner, and I'm happy to be spending some time with you to discuss outbreak investigations. I'll say a few words about myself first by means of introduction. My training is not as an epidemiologist, but rather as a medical doctor, although I've spent most of my time and career taking care not of individual patients, but working with communicable disease control problems at different levels. So, for example, at the state level with the South Carolina Department of Health and Environmental Control, or DHEC as we call it. Also at the national level with the Centers for Disease Control, or should I say Centers for Disease Control and Prevention, since we would rather prevent diseases than control outbreaks once they've occurred. And I've also worked internationally with the World Health Organization, both in Geneva at their global headquarters and also on various short-term consultancies for them. And as we talk about disease outbreaks, I'll have a chance to refer to some experiences perhaps at all of these different levels. I believe you've had the opportunity to look through a case study or discussion of an outbreak of hemorrhagic fever, possibly Ebola, in Uganda, which makes sense since we know that the home of Ebola is in Central Africa. Uganda is more in East Africa, and a few years ago, as you recall, we had Ebola in West Africa, in Sierra Leone and Liberia and Guinea. But that certainly is a dramatic example of a disease outbreak which needed to be investigated. And what we'd like to do today is think through a little bit, reflect on the steps that are needed to approach a disease outbreak. What would one do? What would a health department do? What would you do? Or what would you and your colleagues do when faced with an outbreak? Notice I say you and your colleagues because we'd like to keep in mind that public health is not an individual sport. It's not like tennis. It's more like soccer, shall we say, where you have a whole team and the team works together. So these will be somewhat informal reflections. I will refer from time to time to some of the books on my desk here and to some informal notes that I have. So one of the first questions we should ask ourselves is just what do we mean by an outbreak? And there are actually several ways to think about that question. A commonly used definition is that an outbreak occurs when we have more than the usual expected number of cases of some disease occurring at a certain place and a certain time. Well, how would we know what the normal expected number of cases should be? And that information in public health we get from our disease control surveillance system. So you might say that a surveillance system which lets us tally cases of tuberculosis or foodborne outbreaks due to salmonella or measles or West Nile virus fever or Ebola. Whatever the disease is, the surveillance system which tallies cases over time gives us a baseline against which we can then try to assess whether or not we have an outbreak. That is the observed number significantly higher than the expected number? So that is one way to think about what an outbreak is. We should refine that a little bit more because for diseases that are very common, such as influenza, supposing we were in Columbia, South Carolina in February, and we heard that there were 5 cases of influenza in a high school. Would that be an outbreak or not? And the answer is probably not, because in January or February, that's the middle of flu season, and it's not unexpected that we would have 5 or 10 or more cases occurring in a particular place at a particular time. But supposing you had 5 cases of paralytic polio, supposing you had 4 cases, supposing you had just 1 case, would that be an outbreak? And the answer is yes, because polio has been eliminated from the United States. and the occurrence of even one case would be more than the expected number and would absolutely warrant an investigation. I'll just add parenthetically that as we are speaking now in October, actually November now, 2017, polio is occurring only in 2 countries in the world, in Afghanistan and Pakistan. So if we had one case of polio, that would of course be an outbreak that merited to be investigated. Another question is, how may outbreaks come to our attention? So I mentioned already that one way is just to look at your surveillance data and say, oh my goodness, the number of cases, we usually expect to have 10 cases per month of disease X, Y, or Z. In this month so far, we have 40 cases. That's not normal. Something is going on, so that we can get some inkling by looking at the routine surveillance system. But sometimes things come not through the formal system, but come through communications, which could come from private doctors' offices, from a hospital, where typically the call might come from the infection control committee or the infection control nurse, or as we say now, the infection control practitioner at the hospital. Information might also come from diagnostic laboratories, because after all, they are the ones who are doing in the laboratory diagnostic tests, such as cultures for particular viruses or bacteria. And the laboratory might call up and say, oh my goodness, we usually see 2 or 3 cases of tuberculosis per month, and so far it's only the 10th of the month, we've seen 15 cases. Something seems to be going on. Now, of course, we would hope those cases would have been reported also by the physicians in hospitals as well as by the laboratory, but this illustrates the fact that it's useful to have information from several different sources which you can then put together, and so much of public health depends upon having a network of good information providers. Sometimes outbreaks might come to attention because of a concerned citizen. A school principal might call in, or the head of the PTA, or just a mom down the road saying, up in my child's daycare, we seem to have several cases of whooping cough. So that might even short-circuit the medical care provider discussion, which you mentioned before. And who knows, sometimes the press may get onto something because someone has called a newspaper or the TV station, or sometimes people might even call their legislator saying, do something about this, something's happening in my church. Well, in any case, from a variety of sources, whether formal or informal, word may come in that something is going on. Then the question is, what is going on? First of all, maybe it is an outbreak, but then again, maybe not. So let's think this through a bit. First of all, there could be an increase of cases, but in a way that the cases could be connected together. For example, many people getting sick after having eaten a common meal at a PTA dinner on a Friday night at the local high school. And that would be suspicious because they all had a common exposure at the same site, ate at the same meal, and all got nausea, vomiting, and diarrhea following that same meal. That sounds very much like a foodborne outbreak. But supposing you find that there's an increased number of cases, but they are occurring in different localities amongst people who do not know each other. In South Carolina, you might say, well, what if we have 2 cases in Spartanburg, and 1 in Charleston, and 2 in Florence, and 1 in Beaufort, and 1 in Calhoun County? Is that an outbreak or not? Well, that's part of what the investigation would need to try and ascertain. Not always so easy in this circumstance, but maybe there is a common food that was eaten or purchased at a certain store, but was not consumed at the same meal. So that would be something that further investigation could clarify. Now, outbreaks could also be false positive or false alarms in several ways. First of all, the kinds of diagnostic tests that we have in infectious diseases are always evolving. Supposing a new test has come out just in the last few months, which is more sensitive than previously available tests. And the number of cases may be going up, not because there is a true increase in cases, but because diagnostic capabilities have improved. Something to bear in mind. That's a technical point, but would have to be discussed with experts in that particular field. Another possibility, and this is a little bit subtle, is that the definition of a case of a certain disease might also evolve. And you may wonder, well, what does that mean? Isn't measles always measles? Well, the disease probably is the same disease now as it was 10 years ago, or 20 or 30 or 40 years ago when measles was common. But if you look even at the CDC website and look for their case definitions for different diseases, for example, for measles, you might find a whole series of case definitions, one from 1980 and one from 1990 and one from 2003 and one current one. Why is that? Because as time has gone on, new laboratory methods may have been developed such that new case definitions are using newer diagnostic criteria from newer laboratory methods. Or case definitions may change because the epidemiology of the disease has evolved over time. Let me clarify with an example. In the United States now, if we have a case of suspected measles, we would do special tests, PCR, that's polymerase chain reaction tests, or looking for IgM antibodies, a certain class of antibody which goes up following an infection. But we would not depend just on the clinical judgment of a doctor in an emergency room. After all, those doctors don't have experience with measles anymore, and the young physician may say, oh my goodness, here's a child with fever and rash, I'll tell the mom the child has measles. Well, maybe it is, but maybe not. So the definition we have in the US requires laboratory confirmation because the disease has become uncommon. But if we were in Mozambique or Angola or Nigeria, the case definition used there might be fever and rash and conjunctivitis and other kinds of clinical signs, or laboratory confirmation, or the diagnosis as proposed by an experienced healthcare worker. So in those settings where measles is common, they can use a clinical definition as observed by a healthcare worker, whereas we could not do that. After all, in Angola, every healthcare worker knows what measles is. They see it every week. Actually, every mom knows measles because all the children in the community, or many of them, have had it as well. So this shows that the case definitions that are used in different places and different times must be taken into account as well. Now, another possibility for an increased number of cases could be that the sensitivity of the surveillance system has improved. Perhaps you've learned something about diagnostic tests, where we talk about diagnostic tests having sensitivity, that is the ability to detect that someone has a disease. Likewise, the surveillance system itself may have its own ability to detect a disease. After all, if new funding has come in, let's say from CDC, saying, yes, we'd like to give you an extra $200,000 this year for 3 new epidemiologists to help with the surveillance system, and to buy a new computer system so you can have web-based disease reporting instead of just sending in postcards. Well, the surveillance system may have improved such that we are finding more cases, not because there are more cases there, but because we've improved the ability to detect those cases. So in a way, this is all common sense. I hope so. In some ways it sounds, oh my goodness, why is everything so complicated? Well, it's not really. It just reminds us that we have to try and think clearly about what is going on or what may not be going on. Now, let's assume that there is an outbreak, and we have to ask ourselves now, why do we want to investigate this outbreak? And there could be, well, You might say, well, we want to stop the outbreak, and that would be one reason for sure, but there could be a variety of reasons. So the first perhaps is the one that we just mentioned. We want to control the disease, stop the spread of disease, halt the outbreak so that we don't have future cases. We're trying to preserve public health. But beyond halting the outbreak, we also want to do something else, which may be to ascertain the causes of the outbreak. Why did this occur? Because if we can do that, this may help us take measures to prevent a subsequent outbreak, which could be due to the same causes. A third reason for investigating an outbreak may be to learn something. So it's not just for practical reasons to preserve health. It's also to increase our knowledge about the disease in question. You'll recall that last year there was a lot of talk about Zika virus infection in the community, and it was important to investigate not just to try and control Zika, which actually is a vector-borne disease and requires mosquito control and prevention against getting mosquito bites, but we learned a lot from investigating about different modes of transmission. That is, it was not only mosquito-borne, but also could be transmitted sexually, could also be transmitted from mother to child, could also be transmitted possibly by blood transfusions, and in one or two cases possibly transmitted from person to person as well. So when we investigate, there's a chance not only to stop something from happening, but to improve our knowledge of the disease in question. Now, we need to keep the context in mind also. So if we are about to investigate an outbreak, one question to ask ourselves is, where are we in the outbreak? And if you would kind of think of an epidemic curve of rising up like this, more and more cases, and then flattening out and then going down, or are we investigating just during the upslope? We're trying to keep it from going even higher. Or sometimes, by the time we learn of an investigation, things are already on their way down, and maybe they would come down without our investigation. That's one of the things to ask yourself also. Some epidemiologists, even at CDC, joke, yes, whenever I'm sent out to investigate an outbreak, it always resolves, but I came in as it was coming down, and I rode the downward tail of the epidemic curve to its logical conclusion. Well, so it's important to try and keep the context in mind. And as we think then of the steps of an outbreak investigation, let's make a little list, and I think you've had a list proposed for you. There are numbers of such lists. Some give you the 8 steps for an outbreak investigation, and sometimes you see 10 or sometimes 12. And they are all variations on a theme. Sometimes it depends which book you pick up. For example, here's one of my favorite books. It's called Field Epidemiology. And I like this a lot because it's not, shall we say, not academic epidemiology as done by someone sitting in an office in a school of public health, but epidemiology as would be practiced out in the field in real life situations. Here's another interesting book, Infectious Disease Surveillance. How do we know what's going on in the real world about different kinds of diseases? This book will also have a chapter about steps in the field investigation. And finally, oh my goodness, here's one called Outbreak Investigations. That's very convenient. Outbreak Investigations Around the World. This would be a very rich source of information with actual descriptions of outbreaks that have been investigated in Africa, in New York City, Ebola, hepatitis, and so forth. Very interesting. And if you look at 3 different books, you actually may find that the list of steps may be slightly different, but if you look carefully, they are very, very similar. Let's go through some steps. The list I have says prepare for field work as the first step. Before you're sitting in your office and you're going out to investigate, prepare for field work, establish the existence of an outbreak, verify the diagnosis, define cases. What is your case definition? Describe the epidemic. Formulate a hypothesis about what is going on. Test or verify the hypothesis. Refine or reconsider the hypothesis as needed. Implement control and prevention measures. And finally, communicate the findings. This would be similar to ones that we've seen before. And let's take just a minute or two to think of those individual steps. Preparing for fieldwork. This could involve basic things such as reviewing the literature. I might look up in a book and see, oh my goodness, has this kind of outbreak been described before? Or actually go to the CDC website and look up in the Morbidity and Mortality Weekly Report, the MMWR, and I could see if other outbreaks due to this particular agent, whether it's Ebola or Salmonella or cryptosporidiosis or measles, has been reported. Likely it has, and read through several outbreak investigations and see what people learn from those. Another important step, besides looking at literature, would be to talk to an experienced colleague. It might be someone in the office next to you. In my own experience at DHEC, we did this all the time. We would run down the hall and we called out, holding hands. Hey, I'm on the phone with somebody, they're describing such and such an outbreak. Have you ever dealt with this? And get some good tips from them. Aside from talking to colleagues, you can also talk to what I call SMEs, subject matter experts. That might be someone who's maybe not even in your office, but could be someone in a different academic institution, could be someone at CDC. That is someone who spends most of their daily or weekly or yearly professional life focusing on a single disease. So those are people who keep up with everything in the literature. It doesn't mean they would necessarily be the best person to have working in the office next to you, but they're very valuable people to talk to about what's going on. And then before you would rush out in the field, it would be good to say, gee, when I get out there to Charleston or Calhoun County or Beaufort, who is there in that locality who could be my contact and my colleague who will know something about local conditions? It could be a colleague from the health department or someone from a hospital or a friend. Next would be to establish the existence of an outbreak, but we've discussed that before, looking carefully at the data and try to work out carefully, is this really an outbreak or is it kind of a false blip? Then in terms of the diagnosis, I think it's important to do a couple things. One is to review not only case reports, but to review laboratory data. If you're dealing with Ebola, are these just clinical descriptions, or do we actually have laboratory confirmation? And also to write up a case definition. What is the definition of Ebola or measles that we're going to use for our investigation? Because the definition that are used for surveillance purposes are not sufficient for what we will be doing in an outbreak investigation, because the definition in an outbreak investigation would include clinical and laboratory information, but also, and I'll give you an example, supposing that this is an outbreak that relates to people who ate at a church supper on a certain Sunday, and here we are on Tuesday, and many people have nausea, vomiting, fever, and diarrhea. So a case definition might be the onset of any two of the following four things: nausea, vomiting, diarrhea, and fever, following attendance at the church supper at the First Baptist Church on Sunday, September 17th, or in the absence of the symptoms, a positive stool culture for salmonella. So that way I have in my case definition some clinical information, some laboratory information if it's available, and the time and the place in which I'm interested. So that would take a little time to work out, but will then help guide the information. Another step could be then to find or search for other cases. Remember, the surveillance system that we had initially might be called a passive system. That is, someone is sitting at the DHEC office waiting for reports to come in from laboratories or the hospital. But in an outbreak, you may want to do active case finding. That could be, for example, that involve you or your colleagues making daily phone calls to emergency rooms in hospitals in that area saying, have you seen anyone in the last 24 hours with the following symptoms or diagnosis? And you're likely to find more cases that way than if you just sit in your office waiting for information to come in. So after you have accumulated cases, both from your passive surveillance system and from active case finding, an important thing then would be to describe the epidemic in the following ways. First of all, you should be able to answer the question, how many cases? That is, you're counting the number of cases that you found through active and passive surveillance. The next question is, cases of what? That depends on having formulated a clear case definition. So now you know you've answered the question, how many? And you've answered the question, what? But now you want to characterize the cases by time, place, and person. So by time means by onset of disease, what was the date? Possibly even the hour of onset, but at least the date. By place, where did this occur? In what city, county, or state, or what neighborhood? And person, usually that would be what was the age of the person, what is their gender, and other characteristics of the person. And if you think about it, if you get information about time, that answers the question, when? If you get information about the place where these people are, that answers the question, where? And if you get information about the person, that tells you who. So if you think about it, just by going through these simple steps, you now have information about how many, what are you talking about, when did it happen, and where did it happen, and who was affected. Wouldn't it be nice if you could know that for all the cases in an outbreak? You would know a lot already. And all that I call descriptive epidemiology. And by the way, for those of you who like to play with computers, Excel is a wonderful tool to make what's called a line list, where each patient in the outbreak would have a particular line, and each column would have a different attribute, such as the age, the sex, the time they got married, where they live, where they work, where they reside, and so forth. And from such a list, it would be easy, even with Excel or public health tools such as EpiInfo or professional statistical software such as SAS, using many kinds of tools, or even by hand tallying, to do good descriptive epidemiology. But beyond that, we want also to answer another question, not just who and where and how many. We'd also like to know why. So to do that, we may go on to the next step, which might be to formulate a hypothesis. What were the risk factors leading to this particular outbreak? And your hypothesis might be based on information from this event, also from a review of information from events in the literature. And you may begin sometimes with what are called hypothesis generating interviews. Speak to a number of patients. How do you think you got sick? They can give you ideas as well. Then you formulate a hypothesis. And the next step now will be to test the hypothesis. So at this point, this is not just descriptive epidemiology. Some people would call this now analytic epidemiology. And if you've had a course in basic epidemiology, you might say, oh my goodness, and you would be right. This is a chance to do a retrospective cohort study or a case control study. For example, your hypothesis might be that people who got nausea, vomiting, and diarrhea and salmonella were people who ate a certain food at the PTA dinner. So then you would make a 2x2 table and you say, well, for each food item, who ate it and who didn't, and amongst all the people who attended, who got sick and who didn't. And then there'd be a standard way of calculating what the risk was of getting disease if you had had that particular food item. But to come back to the example of Ebola, if you were investigating an outbreak of Ebola, one hypothesis might be that people who attended a funeral of a previously deceased patient with Ebola were at risk, and then you could do a test of that hypothesis by saying, oh my goodness, of all the people in this community, let us see if we can ascertain who developed Ebola and who didn't, and who had attended this particular funeral and who hadn't. And there would be a simple way to put this into a 2x2 table and calculate the relative risk or the odds ratio and be able to see if attendance at a particular funeral were perhaps using traditional African ways of caring for the body. Male patients might be shaved, or for women patients, maybe the hair might be braided and the bodies might be washed and then dressed in a certain way. That certain cultural habits and traditions that are used in funerals might have been the risk factor. Then a next step might be to implement control and prevention measures. And depending on what you've found, actually it could be common sense. For example, if your investigation suggested that it's people who ate at a certain restaurant who got sick, maybe a preventive measure might be to close the restaurant. Or if people who had a certain gastrointestinal illness lived in different parts of the state, but you had found that they had a particular food that they all bought in common, you might have to work out with the FDA to have that food item recalled. So the particular step would depend on what you found. Another example from my own experience was an outbreak of diarrheal disease from children who swam or who bathed in a splash pad at the Drew Wellness Center on Hardin Street. And the problem there was that the water had not been properly chlorinated. Actually, it had been chlorinated, but there was a lot of debris in the pool under the splash pad, organic debris which absorbed the chlorine, and the preventive measure was to clean out the debris and hyperchlorinate and kill off the pathogen that was causing the diarrheal disease. Or if this is now a matter of Ebola being transmitted at funerals, then the preventive measure would have to involve, and this would be tricky because this would be not only administrative measures but cross-cultural measures that might have to be discussed with community leaders, even with religious leaders, about education of the community about the dangers of taking certain measures during a funeral with the body of a deceased, how not to do that or to have it done in a safe kind of way to prevent further transmission. And finally, then, we have, when all this is done, the last step might be to communicate the findings. And this could be thought of in different ways. So, of course, you want to communicate this to all the partners who've been collaborating with you on the investigation. If you've been dealing with the community, you need to communicate this as appropriate to the community, whether it's people who attend church functions, or teachers and students who attend a school, or the PTA, or in an African village with Ebola, you'd have to communicate this to the village elders and so forth. There might also be the need to communicate this to the press and the media if they've been involved with following the outbreak. That would be very important. And finally, especially if you've had some new findings that could be useful for others in the future, would be to write this up in a formal report, or even in the form of an article which could be published and become part of the literature that future colleagues then would be able to refer to when they were doing their own investigations. Now, in conclusion, let's think a little bit about these steps that I've just been through, whether it's 8 steps or 10 steps. We've been through them sequentially. Now, does that mean that in the real world you have to follow these steps, for step 1 and 2 and 3 and so forth? And the answer is no, because in the real world you have to be flexible according to circumstances. For example, if it seems quite clear almost from the start that infection is due to, or the outbreak is due to a particular restaurant, you don't have to wait till step 10 before you close the restaurant. That might be done early on, even while the outbreak is being investigated. So common sense would prevail there. And I suppose an analogy might be, from everyone's experience, supposing someone gave you the 10 steps to follow when you were given a term paper to write. Well, what are the 10 steps? I'll read you a list of 10 steps. Select a topic, get approval from the professor that the topic is okay, consult textbooks, review the published literature, review authoritative websites, discuss maybe with a friend who has experience in the subject matter, prepare an outline of the paper. Step 8, write a draft. Step 9, review the draft. Step 10, write the final version and turn it in. All makes perfect sense. But in the real world, are those exactly the steps you're going to go through every time? Well, maybe or maybe not. Maybe step 1 might be to attend a lecture which is being given at noon tomorrow in your department. That might be step 1. Or maybe you know enough about the subject to go right to the outline because you did something like this last year for another class. So things may vary. Or maybe as you're starting to think it through, you say, well, my subject is too broad, I need to narrow it. Maybe you picked a topic just to write a term paper about AIDS. You say, oh, that's too broad. Maybe you just mean AIDS as transmitted from mother to child. Or maybe I mean AIDS transmitted from mother to child just in developing countries. So there could be many steps which could change as you go through the process. So in conclusion, I think it's good to have a list of steps as have been proposed to you, or as you can see in many of these books here. And those steps remain a useful guide. It's a good example of the fact that public health is complex, and it's good to have a guide to the things that we do. But it also points out the tension we have between being organized and structured and yet have the need to be flexible in what we do. That's something very important in public health. Sometimes we have structure to follow step by step, but sometimes we have to be flexible. And finally, always need to remember that an outbreak investigation is done not on your own, but with a team, and that in public health outbreaks, we work as a team because public health, after all, is a team sport. Thank you very much for listening through.